Hi, I'm Dr. Eric Westman, and this is the Keto Made Simple podcast. Let's begin.
Hope you're doing well. We're getting into the hot time of year here in North Carolina, and then it gets cold again and then hot again. So it's very interesting here. You might be going to see your doctor for an annual physical or for checkups. And so tonight I thought I'd give a talk and I'm going to, go over some of the background as if you didn't know anything about me. I thought many of you have never really heard my story of how I got into this and how I got involved. It was not my own personal experience. It was out of the research. And then some insights into how to talk to your doctor, healthcare provider, dietitian, family, all of that from what I've seen people tell me and then what other doctors have told me. I'll try to give you some insights into that. So here we go. Back to the good old PowerPoint slides. So the talk I titled was, they helped me. That kind of shapes the title is Enlighten Your Doctor. How to talk about nutrition and lymphatic fat disorders with your healthcare provider. Now, if you don't know about the lymphatic disorder group, lymphedema is a term you may have heard, or you may have it yourself. It's a group of folks who have very difficult fat loss issues, even more than the average person. And usually it's a body part, the legs, the arms that are particularly affected. But the low-carb keto diet can work, but it often folks with this problem, and maybe even like you, will come to it thinking there's nothing that will work. They've tried everything, and yet keto will work for this. So that's kind of the context. I know I'll be talking to a group of people who feel like they're the only ones with the problem, and they feel like nothing can help. That's generally this group of folks. Now, for every talk, I give sort of an academic disclosure. You may have seen my videos at dietdoctor.com. On the upper left there, I've had a lot of videos that Diet Doctor has used. I'm still an associate professor of medicine at Duke and director of the Keto Medicine Clinic, which we established in 2006. And I've published over 50 peer-reviewed papers on the keto diet. I try to keep to what I talk about from my clinic and from my papers. Try to keep it as scientific as possible. But you may not have known that I'm the past chairman of the board of the largest group of medical weight loss doctors in the world, called the Obesity Medicine Association. So I'm well aware of all the different ways that you can lose weight or change your metabolic health. I'm also co-founder of Adapt Your Life, which has a few keto products, but it's mainly an education company now, trying to get the word out to as many people as possible, as you know, with the ALA group. And then I am author of End Your Carb Confusion. In fact, with the cookbook now added onto this slide. But these royalties actually go to the company. I don't get them personally. And then I was involved with books called Keto Clarity and Cholesterol Clarity that were mainly written by Jimmy Moore, who was a very clear writer, very simple writer. But those still have valid sets of information in them too. Although the End Your Carb Confusion is the latest thinking of mine. So my contribution, I didn't come to this from my own personal experience of needing to lose weight, although I have that sort of metabolism. I came to this because two of my patients lost weight at the VA where I was working in about 1998. And it was remarkable because nobody really lost weight in my clinic. I'm working in an ambulatory care, internal medicine setting. And so it was, remarkable that two people lost weight. So I said, well, what did you do? And one of the gentlemen was shock value, said, all I did is eat steak and eggs. And I know, well, that's interesting, to eat steak and eggs and lose weight. And so 2 in a row, these 2 patients came in losing weight, doing the Atkins diet, basically. I didn't know much about it and started to learn about it. And I said, well, your cholesterol must go up, so don't do it. And one of them said to me, he looked me in the eye and said, well, I checked my cholesterol. You're a doctor. There's a lab down the hall. And so we did. And in 2 in a row, the cholesterol got better, even, if you look at it the old way and the new way. So I was introduced to this area of eating and nutrition by 2 patients who had success and told me about it. So we go to the literature. There had been a taboo on studying low-carb keto diet. Taboo means there's no written law against it. There's no rule that says you can't study it. It's just kind of a societal acknowledgement that no one wants to study these things. And we tracked back. It was because of this paper in 1990, because in 1980, of course, this, for me, it's about 1998. I'm trying to learn about this. We go to the literature. There was this paper in the Journal of the American Dietetic Association where they put 24 obese, but otherwise normal men and women 2 weeks on their usual food intake, 8 weeks on a high-protein, low-carb diet, and then 2 weeks again on their usual diet. And so basically, it was a 12-week study, 2 + 8 + 2. And they saw the weight came down, substantial weight loss, the triglycerides came down, and however, there were significant increases in LDL cholesterol, uric acid, and free fatty acids. The HDL levels failed to rise despite significant weight loss. And basically, inside this article, they said, don't do this diet, it will kill you, because of that LDL, even though the abstract is kind of lukewarm. But this was the study that basically said no one should study this diet. Meanwhile, Dr. Atkins and Eads and all those diet book authors were using it with great success. And so by today's standards, this study is not good enough to say this is a bad diet. By today's standards, you would make no judgment about a drug or a diet on just 24 people. By today's standards, you wouldn't make any judgment on a diet like this without a randomized control trial. So Jeff Volek and I crossed paths at that time doing a literature review, and he kind of agreed that there hadn't been any research on this. So nobody knew that it was bad. It was just assumed to be bad. So we both, in the same month of 2002, had papers that came out. The one on the left. So I'm the MD of the 2 groups that did the research then. He's the PhD. So I'm dealing with real people in the real world going out to live their own lives. And he's dealing with things on more of a, ideal level, brings in healthy people and sees the metabolism changes. And we published these 2 papers, and they both were positive papers. People lost weight, the parameters looked good. And so when someone asked me, what about the blank diet? Like there was a Dukan diet, Dr. Dukan, a French doctor. And I said, well, show me a paper with 50 people in it, where you follow them over 6 months, and I'll publish it in a peer-reviewed journal, and I'll comment on it. Because that's what I thought had to be done before you're ever going to talk about a diet. And we did that in 2002. So a long time ago. The studies kept coming out, and people started doing randomized trials. We did too. So over the last 20 years now, the studies have really been positive. So it's not that other diets can't work. It's just low-carb diets work pretty well and work better in many cases. So I started to think, well, gosh, the papers are done. Why aren't people following this? Why isn't the world changing? Science changes everything, right? Well, that's the naive young Dr. Westman. So someone asked me, would you be on the cover of Woman's World in 2014? I said, sure. And I don't know, nothing really happened then, but like David Ludwig at Harvard was on the cover of these peer-reviewed journals that your grocery store checkout. And then again in 2021, and I came up with the term prescription strength keto because by now the internet keto had started to blossom and people were getting all sorts of strange ideas about adding oils and eating fat bombs and things that I really hadn't studied and hadn't learned about. But recently at some of the Adapt events in February, I showed a similar slide like this, and a couple of people came up to me and said, "I had no idea you did those research papers. We saw you because you were on the cover of Woman's World." And so I joke about that this probably has had more influence than the research papers, although we helped to set the stage for other people to do research. And I think looking back, we were instrumental in getting the science, the scientific community to acknowledge that, yes, this is valid, this is reasonable to do, even healthy for many people. Other experts started saying, well, sure, low carb should be at the table, and the best diet is the diet you can stay to. If it's low carb, that's great. So getting the pop culture to change is a whole different sort of thing than doing research. And so my upbringing is in clinical trials and in medical community. I've been at Duke since 1990, and I was asked to be part of that leadership of the Obesity Medicine Association. So we started to influence the doctor's way of thinking and teaching about low-carb diets. And the Obesity Medicine Association has a guideline in a form of an algorithm, and we were able, because of the science that had been done, to get the low-carb diet in the middle and the bottom here of this slide into the guideline of the Obesity Medicine Association. So here, as you see, this is kind of the diet slide. On the far left, you can do a restricted fat diet. Can be a low-calorie diet. You can do a restricted carbohydrate diet. And then in the medical weight loss world on the far right, there are programs that doctors can sell you where they don't, they ask you not to eat any food, and they just have you drink the shakes and eat the bars. These are called OptiFast, MetaFast, or Robard, not the over-the-counter versions, but actually the prescription strength from the doctor. I don't do one of those programs in my office, but they are available in our area. But so the low-carb science is in the Obesity Medicine Association algorithm. The Diabetes Association started to support the low-carb diets as well. This is a paper that was shepherded and my colleague at Duke, Dr. Will Yancey, you can see his name at the end of the list here in alphabetical order, was helpful in getting this paper out, showing that the data really are good for diabetes as well. And then there's a new organization called the Society of Metabolic Health Practitioners that has a clinical guideline on using therapeutic carbohydrate restriction or low-carb diets for the use for obesity and metabolic health improvement like diabetes. So if anyone says that, well, the American Heart Association guideline says, or someone else's guideline says, well, that's fine. But there are guidelines that support the use of low-carb diets. A lot of these guidelines are political and do not reflect any other sort of science. And so you have to understand there will probably be organizations that are against low-carb diets forever, because that's not the purpose of their organization. It's not why they were founded. But the clinical practice is supported by national, international guidelines to be able to use low-carb diets. And this, I hope, gives you confidence that it's not just me talking about it. It's not just, Dr. Atkins or Dr. Berry or Dr., whoever the doctor today. This is the groups of doctors getting together, looking at the science, putting together solid guidelines for people to follow. And then this is taken for me to follow this. It's been over 20 years for this to grow. Jackie Eberstein, who's helped me, she's the nurse that's worked with Dr. Atkins, used to work with Dr. Atkins for 30 years, and she sent some videos for us at the ALA Hub, some interviews. She's now been in this world for about 50 years. So the confidence that I have in my office when someone comes to me, someone recently said, "Boy, you're really confident this it's going to help me and it's going to work. I say, yeah, I've seen it. This is like a prescription drug. It will work. So back to this organization, the Lymphedema folks, I bring back the most important points about the carbohydrate insulin story, that if you want to improve your metabolic health, keep the insulin level as low as you can, which means you want to keep the blood glucose level as low as you can after meals. That just shows the spike after a meal with carbohydrate. So I'm sure you've seen this in different forms. The obesity and type 2 diabetes have a common cause. It's excessive dietary carbs. And I put this in here because your doctors may not know this. Your dietitians may not know this. They might still be talking calories, thinking calories is the only thing you have to worry about, when it really is about the carbs. And it's because the blood sugar goes up, the insulin goes up, that causes increased fat storage, which causes the blood sugar to come down. You have low energy mood swings, you have carb cravings, you increase your carb intake, and you go around and around. Plus you get chronic inflammation as well. So just recently, and recently means in the last 6 months, there's a big paper that's trying to change the model of calories in, calories out to the carbohydrate insulin model, and it's written by David Ludwig at Harvard, and I'm an author on these papers. I don't have the patience to do what David is doing now, writing these papers and assembling all these different experts, but this is slow changing undercurrent that hopefully eventually will at least get into the doctor training, that there's more to it than just calories. And then, when I was trained in the 1980s, low-fat diets were everything. And so some of the doctors you meet have to unlearn what they've been taught. And here, the slide is a classic one from the Atkins era. I just took out Atkins and put in keto. You went on keto and lost 90 pounds, lowered your cholesterol, cured your high blood pressure, and now you're walking 5 miles a day. And I'm warning you that keto diet's bad for your health. Or you could insert here, you went on keto, lost 90 pounds, lowered your triglyceride, but your LDL went up. So I'm telling you that low-carb diet's bad for your health. In fact, that's a slide I think we need to make on our own, because that's, have you heard that yet? About that LDL? I'll get to that in a minute. Now, to help you unlearn things, I used to use a pen in my class and say, this is a pen from the Neuralizer from Men in Black movie, and I can erase everything about nutrition, and so I want you to forget about what you've learned, which means you don't have to have breakfast if you're not hungry in the morning. I had someone recently who was just so relieved. She laughed, and she said, "Really? The tragedy." She said she's been eating breakfast all of her life because she thought she had to. She hated breakfast. And the tragedy is she had weight loss surgery because no one had told her, well, among other things, that she didn't have to have breakfast. Isn't that crazy? So you don't need a magic wand to reprogram your mind. One of the people who heard me do this in the class sent me this Neuralizer in the mail, and I had it for a while. It makes a little noise. This is one of my medical students being the model Neuralizer holder here. But so you might have to erase what you've been taught before. It's okay to eat fat. It's okay to have salt. All these different things that you thought were the right way to go about things. So stepping back, I've become an old doctor. I don't know quite when that happened. It goes by fast. Did it ever occur to you that medical care today means medication care today? So there's a medication for everything. And there's usually one medicine for one condition. So you get diagnosed with high cholesterol, there's medicine to lower the cholesterol. You get diagnosed with hypertension, so there are medications to lower the blood pressure. You get diagnosed with high triglycerides, so there are medications to lower the triglyceride. As Jeff McDaniel in Atlanta says, there's a pill for every ill. And when was the last time a doctor asked you really about what you ate, like to write down everything you eat and drink for a day and to examine it carefully? I do that every time people come back. Doesn't take much time because I ask people to write down what they eat and drink before I come into the room. I just scan it and I can figure that out pretty quickly. The metabolic syndrome leads to diabetes, and you have medicines to lower the blood sugar to treat the diabetes. Metabolic syndrome leads to heart disease, and there are medications to facilitate heart function. So all of these medicines, I'm afraid, treat the underlying lifestyle. And I put this up here because this is just the way doctors have been trained. They are trained this way at Duke University today, that there's a medicine to fix something. They are not trained to talk about lifestyle, or if they are, they're just taught a very narrow view of it. And you have to understand that in order to engage. And it's not your job to teach your doctor or your health provider, I don't think, but you can try if you want. But I wait until the doctor wants to learn for me to intervene, because there's going to always be a, well, what about that? What about that? What about that? Because they're not given the fundamental training about what this dietary approach can do. So how are health professionals taught? It's good to know this, to understand the old paradigm. Medical teaching is based on this old way of thinking. And then, fat in the diet is bad. Low-fat diets fix everything, or the Mediterranean diet fixes everything. There's really no science for that, but that's what people say. Second bullet here, we now have a group of doctors or nurse practitioners and physician assistants and they are taught to follow guidelines. So now if you think about it, let's say we don't train everyone as thoroughly, but we'll give them some training and then we'll just have them follow guidelines. And that's, I'm afraid, what's happened in lots of different areas. You have to understand guidelines are based in the old view that obesity and metabolic disease is a lack of willpower. So old guidelines are necessarily old because there's new information all the time. Even a new guideline means they were looking backwards on old information. Health professionals receive continuing education from pharmaceutical companies, which drives that, a pill for every problem, talking about medication treatment of things rather than changing the food or treating the root cause. The lifestyle is the cause of the problems. Treatment of medical problems with medication is profitable for companies and for doctors, I suppose. You see more patients, and it takes very little time. It often takes me, 15 minutes to just talk about the food. And if that was the time that doctors had to fix or talk about other things, that it changes the focus. The doctors are taught to prescribe medication. There's very little training in diet and lifestyle. Oh, a little detail about guidelines. No, this is where I get it. Yeah. Sorry, I forgot this slide was here. Guidelines are based on what's happened in the past. I've been on several medical guidelines, and maybe you have as well. You do a review of research studies. So a guideline can't address a new situation by definition. And we talk about guidelines being a not something you have to follow in absolute terms, but just kind of a general approach. But for example, a guideline that includes something related to gravity on Earth would need to be changed to work on the moon, right? Because the gravity on the moon is so different. And what we're dealing with now is a metabolic syndrome or a metabolic change of nutritional ketosis or low-carb diets. And it's like being on the moon compared to eating carbs. So the guidelines are dealing with even addressing problems that have to do with people who eat carbohydrates, which introduces another apples and oranges kind of comparison that probably won't apply. Guidelines are often made because there is no agreement. That consensus. So consensus means compromise, and I learned this a long time ago, where there was a consensus conference where everyone disagreed, and the person got up and said, "Well, the reason we're having the consensus conference is because we know nobody agrees, and we want to bring people. We have to have the image of agreeing on something and compromising." So a guideline doesn't mean everyone agrees on it. And that's why you get multiple guidelines and why it's important to know about the obesity medicine, the American Diabetes Association, the Society of Metabolic Health Practitioners guidelines that include low-carb diets. The final bullet here at the bottom, medical guidelines often include these undercurrents, the cost of treatments, the cost effectiveness, and it assumes that the financial payment is by the payer, the insurance company, or Medicare or Medicaid, and not the patient. And this I learned about a long time ago when I started working at a clinical practice where very affluent people came. This was a program at Duke where people came to town to lose weight. And it occurred to several of the people that they would pay for the test if it needed. If there had to be a payment of it, that they could go beyond what insurance would cover. And that changes the dynamic considerably. And so guidelines and what doctors are taught to do most commonly introduces and it includes the cost of the treatment, which, you may not have to be limited by that cost. But most people are, but it just changes. So decisions are not just based on what's best for you as an individual. That getting into the next one here, there's a population perspective. There's an idea that will make the decision for you. And this will get into that when we talk about the decision to take a medicine for cholesterol treatment, for example. The medical world has said that if it's at a certain level, you should do this, when really it's your choice. We really should tell you whether it's going to help you or not and how likely it is going to help. So there's always that tension of what's best for the population and what's best for the individual. It's not necessarily always congruent. In fact, many times it's at odds. You may be asked to take a medicine with a side effect because if 1 million people take it, we'll save 10,000 lives. When your individual perspective is that you have a side effect and it's not worth taking that because only, let's say, 1 in 100 people will benefit from the pill. I'm writing a paper on it, just explaining the statin medication for cholesterol. And in many situations, if you don't have heart disease, the odds of you getting benefit is about 1 in 100. So for 100 people who are given a statin drug, only 1 will get benefit. And doctors don't tell you that, do they? So to be totally honest, the doctor would say, well, here's a pill, and you have a 1 in 100 chance of it helping you. That's, to be honest, about a statin medicine if you have an LDL of, let's say, 200 and you don't have any history of heart disease. And so anyway, I hope the paper will explain this dynamic in detail. The population perspective means that if we treat 1 million people like you with this drug, then we'll save a lot of lives. But there are a lot of people who will take the drug and get no benefit from it. I think most people expect that you're going to get benefit from the drug that you're given. I would. So expect some preconceptions. Here, this one has to do with medication. Your healthcare practitioner might want to reach for a prescription pad or electronic email now, rather than talk about lifestyle change. It's how they're trained. Because most health professionals do not receive training in nutrition and lifestyle, they may think the only action is to prescribe medications. So when a doctor asked me, what about this new medicine for less and such? And I said, well, yeah, has it been compared to the low-carb diet, which is actually like as strong as 10 medicines? And then, I know the answer is no, it hasn't. So I said, well, I don't know. I'm not going to use it yet. Most health professionals have never seen their patients take action by changing lifestyle. So actually, you may be the first one to go in and show your doctor or dietitian that you can successfully do this and change your lifestyle. So if you want to teach and use that as a point, most doctors don't see people making change. So they get a little bit lackadaisical. They might not try to convince you to change because none of my patients change. So they don't believe it's possible or sustainable. I hear that a lot now. Oh, that keto diet, it helps, but it's not sustainable. And, well, of course it is. If you have support and if you do it and you have, if you fix your diabetes, it's darn right it's sustainable. You don't want to have diabetes again. But a lot of doctors, most doctors haven't seen this. Remind the doctor that you are taking action by changing your lifestyle. Then that may be not given as much emphasis compared to medication, but given time, I've seen lifestyle change do much more than just medication. But then I have a unique view, remember. So how to spot an old paradigm doctor? The old paradigm doctor might print out a pre-created instruction that says you should follow a low-fat or a plant-based or a Mediterranean diet. These are all kind of they're not scientifically backed anymore, but they're the things that computers print out. They may warn you that saturated fats are harmful for you. Hopefully I got you through that, through the modules on mindset change. They might recommend limiting dietary cholesterol as a means of influencing blood cholesterol level. Again, this is not an important issue. Second bullet here, they might just say, just eat less and exercise more. Although I'm seeing this change, the old paradigm doctor might say, well, just don't tell me what you're doing, just keep doing it. So they don't want to know that you're doing something that's violating everything they've been taught, but at least they tolerate it. And that's good. But that third bullet here is they may push you on medications for weight loss without even mentioning a change in diet. And I'm seeing a lot of family medicine, internal medicine doctors thinking that these new medicines are the answer to obesity treatment. And while they can help in the short run, they're not going to be really treating the root cause, which is the diet and the dietary carbs. So the takeaways, how to enlighten your healthcare professional. A healthcare professional is a trained advisor, but it is your body, right? And you should be allowed to actively participate in the decision-making process. You're a consumer of the healthcare services, and you're free to shop around for a provider who's a better fit. Might be more difficult in some HMO sort of system, but usually if you go talk to a manager, you can find some reason or excuse to find someone new. Or you can try to teach your doctor. Final bullet, if you're at a disagreement and you're unable to change providers, compromise a bit and, say, can you refer to me to an obesity medicine specialist? So this is taking away the ego of knowing something. There's actually a specialty called the obesity medicine that most doctors are not aware of. It's kind of an orphan group. There are only 4,000 of us in the U.S. as obesity medicine specialists. But then that will allow you to have these sorts of discussions with a doctor who is trained in the metabolic issues of obesity and diabetes. And then of course, if you want to just say something to please the doctor, say, I am following a Mediterranean diet. And then that will please the doctor. And I bet you won't even be asked what you eat, because nobody really knows what a Mediterranean diet is. So this is kind of like treating ambiguity with ambiguity to just kind of defuse the situation, which is sort of what you have to do in certain situations with people, if you're at an impasse. So just say you're following a Mediterranean diet, and everyone will be happy. So that was the talk I gave for the National Organization of Lymphedema and Lipedema group just last month. I hope that's helpful in your own particular situation. Now that I look back, I didn't go into detail into the old cholesterol way of looking at things and then the new metabolic syndrome way of looking at things. But I hope I got that in your mind, at least in the fourth module of the Keto Made Simple Masterclass. The total and LDL cholesterol is the old way, and the triglyceride and HDL cholesterol is the new way of looking at things. So let me just look. Patricia says, I did the Dukan diet. LOL. I lost 50 pounds, but then put most of it on. You had to make different things every day, not simple like prescription keto. Yeah. So Duquesne, I think it was a low carb, kind of like Atkins type diet. In fact, before Dr. Duquesne, there was a Dr. Montignac, who was a French doctor also, who had a low carb diet that was prominent in France. Let's see, did meditate 2 at a hospital, 5 shakes a day. Well, okay, Medifast. Then Marianne says, I'm going to tell my doc I'm quitting atorvastatin. Well, that's a decision that you can make. In the cholesterol class that I did, Marianne, if you took it, I took you through a website, and maybe Jenny or Kyle, you can put up cvriskcalculator.com, and then the statin decision aid from the Mayo Clinic. These are 2 places where you can go calculate your own risk of heart disease and then see what the benefit would be if you took a statin. Well, to tell you what, because this is so common, let me just go back, share my screen, and take you through one instance of one moment here. So this is designed for just doctors to use, but I don't know any doctor who's going to take the time to do this with you, sadly. So it's the Mayo Statin Decision Aid. So Mayo Clinic, pretty well respected. It's not food, but it's, I'm just joking. In the Midwest, it's probably one of the most well respected organizations, health organizations. So here, this is one way to gauge your own risk and then to see if a statin medicine is going to help you. So what you need is your blood tests and some information here. This is using a algorithm and risk calculator that's commonly known, the American College of Cardiology, the American Heart Association. And so what you want to do, we have to understand this is for people who have not had heart disease yet. So if you do this first question, you say, yes, you had heart attack, it says, you can't use this. So remember, it's called primary prevention. It's for the case that you haven't had heart disease or a stroke yet, any type. So you put your age in here. So let's say you're 60 years old, you're a female, you're white or African-American, if you're a smoker, yes or no, diabetes, yes or no, treated high blood pressure. Let's say you do have treated high blood pressure. And then you put in your blood pressure here from your last clinic visit. Let's say you had a systolic blood pressure of 110 and you had a HDL of 60 and a total cholesterol of 220. What this will do is now sets your current risk. Now, this is great because it puts it in a picture form and it also gives you numbers, which is kind of hits both ways that people learn about things. So your risk for 100 people like you who do not medicate for heart problems over the next 10 years is 3 people will have a heart attack. 97 people will have no heart attack. So everyone in green is going to do just fine over the next 10 years with all of those parameters. Let's say you put in your parameters. So your risk over the next 10 years is 3 out of 100 of having a heart attack. Now, this doesn't include low-carb diets. I think with all of the blood test changes that happen, I think it's even lower. I don't know for sure. I have to be honest about that. But let's say it's the same as for those who eat carbs. So now let's say you go up here and take a statin medicine. Let's say you do high dose. So this is your best outcome using a medication, using high dose. And now your risk of having a heart attack over the next 10 years is 2 out of 100 instead of 3 out of 100. So this is where that weirdness of you're taking this pill, but really only 1 out of 100 people will get benefit from it. So it's kind of crazy? So if you're given an antibiotic, you know it's going to help your infection, right? Just about all the time. But if you're given a statin medication under these circumstances, the chances are is you're not going to get benefit from it. In fact, 97 out of 100 times, you're not going to get benefit out of it. There's only one or 99 out of 100 times, you're not going to get. So you're taking a pill every day, maybe having side effects from it. And can you imagine being the doctor who tells you this in the office? Marianne, you go to your doctor, you pull this up, the doctor is going to be surprised how little effect there is. Because doctors are told that basically it helps everyone and will prevent heart attacks in everyone. So in this circumstance, when the heart disease risk is really, really low, it goes to really, really low, even just a little lower, with using medication. So in this circumstance, I would personally not take the pill because my chances of not having a problem are really high. But if you're someone who is worried about that and you for whatever reason you want to do everything you can to reduce your risk, then you might take the statin medicine. Now, let's say you did the standard dose of statins, it's probably going to be the same. Yeah. And then let's say no statin, again, there'd be no change. You can click on here and they'll give you the issues, the pros and cons, and the side effects. Okay, let me go back to that high dose statin. And it does say here are the most common side effects of high dose statins: nausea, diarrhea, constipation. 5 in 100 people will have muscle aching and stiffness. Liver tests can go up. You want to be sure your doctor's checking the liver periodically. 2 in 100 people need to stop the statins because of that. And then muscle and kidney damage, about 1 in 20,000 people. So it's super low in percentage. But if you're the one who gets it, I've seen kind of miraculous change. It's very uncommon, but someone who is bedridden from having a statin medicine, some doctor finally said, stop the statin, and the guy started walking again. So it can be actually very, very serious. But this shows you again that lowering your risk from 3 in 100 to 2 in 100 from taking the medication. Now, let's assume that you're someone who's at really high risk. Let's say you're a smoker, you have diabetes, your blood pressure, let's say your cholesterol is really low, your HDL, and your total cholesterol is high. I'm just changing the numbers for this hypothetical person here. And you can see now, let me do to the bigger picture, that, let's see. I'm trying to get back to that larger view. Hang on. I think it's taking off the issues. Okay. Oh, well, I can't, I'm going to show the whole thing. Here on the left, with all of those terrible things, diabetes, you're a smoker, your HDL is really low, over the next 10 years, your risk of a heart attack is 27 out of 100. So it's 27%. That's really high. So if you're at high risk and you take a medicine like a statin, high dose statin, now let's look on the far right, your odds go down to 16%. So you're going from 27% to 16%, which is, reducing it almost in half by taking the medication. Still, most people won't have a problem over that 10-year period. But, to me, if 27% means it's like 1 in 4. Yeah, you roll a four-sided die, and if you get a 1, it's you get it. That's high. And then taking a medicine lowers that pretty significantly. I would even say, yeah, this is a good idea to take a statin medicine to treat the cholesterol under these circumstances. So you can see the big difference in the risk reduction from using a medication. Well, your risk at a certain parameters, and then your risk reduction of the same medication has very different effects depending on your underlying risk. So I've been doing a lot of thinking about this this approach, and actually trying to work and get this paper done. It's hopefully will be explaining in layman's terms and even simple terms that doctors can understand the difference in effect of medication for cholesterol treatment depends greatly on your underlying risk. Okay, so let's see. Check out Mayo Clinic. Yeah, so that was the one I just went over. I went to an endocrinologist Monday who wants to be on metformin. My A1C is 5.7. What do you think? Well, I'm sorry, I don't see your name. Your Facebook user to me. Sorry. It depends on all the other parameters, right? Are you at your goal weight? Are your other metabolic parameters, the triglyceride, HDL, looking good? What's your blood glucose level? The diet itself with weight loss. So you do this type of approach, it's 10 times stronger than metformin. And I find a lot of doctors, again, they're only trained about medicine. I'll say, just wait, and wait till you're at your goal and see what the A1C is. If you're at your goal and your A1C is 5.7 and everything else is good, then I need to refer you to the mindset change chamber, where there are some people who the A1C doesn't totally normalize and they don't eat any carbs. And so the measurement has a problem. I don't think it does the same thing when you don't eat carbohydrates. Why would that be? Well, this measurement is based on the red blood cells, the how long the sugar is around the red blood cells, and the red blood cell lifespan changes depending on the diet you're on. So if your red blood cells are living longer, you're going to have a higher A1C. Now, we haven't shown that yet to the level of science to prove that, but that's the underlying thinking, is that these lab values that carb eaters, doctors who treat carb eating people use, don't necessarily apply in the same way to those of us who don't eat carbs. As a dramatic example of that, I had a recent patient who her blood sugars were 200 at home, and yet her A1C was 5.5. The A1C should have been 8. And she looked at me and she was a nurse. She said, I had 3 transfusions of other people's blood before they took the A1C. So actually, the A1C measurement was measuring the blood of other people, of the 3 units of blood, because she had a bleed, lost blood for some reason. She had a transfusion, large transfusion, and basically it normalized her blood glucose A1C, even though her blood glucose was still elevated. So just, I'm an internist by training. Testing was sort of my area that I really like to think about, because often we do the same test twice and it wouldn't be the same, it wouldn't even be close. So you have to kind of understand what is the test really measuring. And so, so depending on those other factors, you might just want to be a little patient and not take a medication. So yeah, the CV risk calculator recommends a statin after you reach a certain age, after 75, no matter what your test result. I'm glad you manipulated the number to see what the change is. So that CV risk calculator is based on an old guideline that is one that pushes drugs. The percent of when you would be on a statin is totally arbitrary. So it doesn't give you that same information that the statin tool from the Mayo Clinic does. And there's a lot of research that is not included in the guidelines that say the older you are, the higher your cholesterol you have, the longer you live. Remember, the studies that are done to show lowering cholesterol have to do with heart disease and stroke, and they don't follow people for that period of time. And so there's a counter argument that after a certain age, you want to have higher cholesterol levels and you don't want to treat it. So so that is a limitation of that. See, Sue says, so many people just take the drugs and don't ask questions. Yeah, thanks for the reminder that this is our choice to make. Absolutely. See, Jan says, Dr. Abbott, who I worked with at the med group, would not refer his patients to our dietitian. He didn't agree with what she taught them. he did hand out low glycemic index foods and a copy of the front of the Wheat Belly book by Bill Davis. Yeah, Dr. William Davis. I met Dr. Davis before. The Wheat Belly, the name of his book. And this was about 6 to 8 years ago. Not all docs did the same. They would tell us to call the patients for the results and to increase fruit, vegetables, low fat, etc., or do the DASH diet. Yeah, and eye roll. Yeah, that's a good one, Jan. Yeah, so I think Bill Davis, I met Dr. Davis, the author of Wheat Belly, on a cruise, actually, low-carb cruise, and Jenny, great to see Jennifer, that you're back on tonight. Dr. Davis was still worried about cholesterol and fat in the food back then. I think he's evolved since then, and I think he's created his own sort of undoctored. I think the last book he had was called Undoctored, and why you want to stay away from doctors, that sort of thing. And you can see my approach is to use doctors when you need them, and use other things as well. But I don't like to do a lot of doctor bashing. I don't know any obesity medicine doctor that uses the DASH diet in clinical practice. It's just not good for that. Anyway, Marianne, thanks for the comment, Jen. Marianne says, before I started internet keto, I was on real keto and didn't know it was bad to be on internet keto until it didn't work. But my doctor told me my cardiac risk went down 2% on actual keto. Great. Yeah. So depending on the calculator, the risk can go down. And that's one thing research papers have shown now. They'll just use a calculator tool that uses more than just an LDL cholesterol to calculate risk. Let's see. Jen says, I don't like statins either. As soon as I had muscle aches, I called and my doctor changed me to Zetia. Yeah, so, a different medicine to change the cholesterol, which you might not need in the first place. But so that's the general approach as well. If this one doesn't work, we'll try this one. See if you have muscle cramps from that. If that one doesn't work, we'll try this one, then the next one. So again, I've kind of fallen out of that sort of practice. Tricia, it's also interesting. Great. Thank you. Regarding my endo, she does not want me to read the diabetes code by Dr. Jason Fung. I did take that as a good sign. Oh, wait. So she does want you to read the diabetes code. That's a good sign. Yeah, great. Yeah. So Dr. Fung, he it kind of got into this in the fasting angle, and you don't have to fast, and fasting certainly works. Just watch that TV show Naked and Afraid. They're totally fasting and they lose a pound a day. So our criticism of Dr. Fung in this scientific world is just that if you do total fasting without eating protein, you're going to lose muscle mass. And so there's a balance of, you want to make sure you're doing it in a healthy way. And I just prefer the flexibility of not telling people they have to fast. In fact, someone recently kind of fell out of their program because they were hungry, but they were told not to eat at a certain time. Now, I prefer the idea that if you're hungry, you should eat, and you're actually getting the metabolism of fasting, which is the fat burning. But Dr. Fung gave a talk recently at our Obesity Medicine Association meeting, and very smart, not a primary researcher, which means it doesn't collect his own data, but reads other people's data and has a population of people that he's treating using the fasting method. So I think it's good information. And yes, it's a good sign that your doctor is not just in the old paradigm. That's right. So Essie asks, why is prescription strength low carb or keto best for lymphedema? Well, so did I say it was best? I say it works. I don't know that it's best. Remember, I'm not going to say it's best unless there's a head-to-head clinical trial comparing low carb to something or keto to something. I think it definitely works. Leslyn Keith, who's a occupational therapist who works with the lymphedema group, did a clinical trial, not controlled, but maybe it was, but it was only about 15 people with lymphedema and other lymphatic disorders, and it clearly can work. I don't know that it's the best approach. I think, stepping back scientifically, you want an approach that lowers the insulin level. Remember, it's insulin that gives the signal to your liver to make fat out of any sugar that's around, and also to store the fat in the fat cells. So there are a lot of approaches that can work for lymphedema because they lower the insulin level. For example, there is a clinic in Germany called the Foldy Clinic, where one of the approaches they use is weight loss surgery. It's for extreme cases of lymphedema, and the weight loss surgery, because you don't eat much, lowers the insulin level and you lose the weight and the lymphedema gets better. So I just wanted to clarify, I didn't mean to say it was best, but it is an approach that's effective. Take care, everyone. Bye-bye.
If you enjoyed this video, be sure to like, subscribe, and hit the notification bell, and check out adaptyourlifeacademy.com.